and I'm going to tell you a little bit about our work on EP and CysLT1 receptors. And the first question is, why do we started to work with these receptors? And, well, the answer is simple. It's because prostaglandins, they may increase in the brain of seizing animals very early. And this occurs even before you have a typical inflammatory response, which is normally mediated by first production of interleukins. So no infections or no properly inflammatory stimuli, they can cause a very rapid increase in prostaglandin levels, particularly PGF2 alpha, PG2, and PGE2 levels. And these prostaglandins, they are synthesized, particularly PGE2, they are synthesized due to the increased neuronal activity. So glutamate, by activating NMD receptors, it increases the production of nitric oxide, and nitric oxide, by S-nitrosylation, it nitrosylates COX-2, which increases PGH2 production, and this PGH2 is substrate for prostaglandin E2 synthase, increasing PGE2 levels. And this work was shown by this one has published 1,000 papers, Dr. Solomon Snyder. And, well, and this is where these prostaglandins come from. And the glycerophospholipids of the membrane, they are metabolized by phospholipase A2 to arachidonic acid in the presence of calcium. Calcium is the main activator of this enzyme. And arachidonic acid is metabolized by two enzymes. Here, it may be the substrate for other enzymes, as we will see. And when arachidonic acid is catabolized by COX-2, it generates mainly PG2, because in the brain, the COX-2 is coupled to PGE2 synthase. So when COX-2 is activated, we drive the arachidonic acid to the production of PGE2. Well, but what are the evidence that prostaglandins are involved in seizures? Okay, it's increasing the early stage, that's okay, but doesn't mean that it's a cause. It may be a very consequence of the stimulation of the brain. In fact, we have some circumstantial evidence and experimental evidence of that. The circumstantial evidence comes from the studies that have shown the increase of PGE2 in these conditions, in epileptic patients and in animal models of seizures. But the real experimental evidence comes from the studies that have shown that PGE2 increases neuronal excitability. It increases the EPSP, excitatory postsynaptic potentials, in hippocampus lysis. And mainly when we have the overexpression of COX-2, in those animals we have increased pentylene tetrazole and canic acid and bicuculin-induced seizures. So overexpression of COX-2 facilitates seizures, and COX-2 inhibition decreases seizures, okay? It decreases not only those seizures induced by chemical agents, but also those seizures induced by electric stimulation. That's very important. Well, so our hypothesis was that COX-2 inhibitors and EP antagonists might decrease the PTZ-induced seizures. Not only PTZ, I'm going to show you only the data that we have with pentylene tetrazole, but we have several other data with pilocarpine and canic acid. Well, the first study that we have done in this, we have treated the animals with celecoxib, which is a COX-2 inhibitor, and then we challenged the animals with pentylene tetrazole. Okay. We also, in a subset of animals, we have implanted the animals with two cannula into the lateral ventricle, as demonstrated here. Okay. So this is the work from Mauro Oliveira. And we have shown that celecoxib increases the latency for seizures, not only the clonic seizures, but also the generalized seizures, and that this follows an inverted U curve of concentrations. So by increasing celecoxib to higher concentrations, higher doses, we have no effect, okay? Well, it is probably because celecoxib starts to interact with COX-1, which is involved in the production of PGD2, as Dr. Reda has talked yesterday. Well, and so that was the first evidence. The second is that, well, if it's really Yes, I did. Well, if prostaglandin E2 was really facilitating those seizures, was responsible for that, we should block this response by administering an antibody anti-PG2. That's what we found. So we injected the animals with this antibody through the cannulas, and we have found that antibody anti-PG2 decreased seizures. This is very important. This was very important at that time because there's an Indian group who defends that the reactive species that are produced during the enzyme cycle of COX would be responsible for this hyperexcitability. In this case, we don't have the production of the reactive species directly. So if we block the effect with the anti-PG2, it means that PG2 is causing the effect, not the free radicals, okay? Well, this effect of celecoxib was blocked by PG2, as expected. So our main conclusions were that celecoxib and anti-PG2 decreased PTZ-induced seizures. PG2 prevented the effect of celecoxib, and low doses of PG2 potentiated the proconvulsant effects of low doses of pentylene tetrazole. But what about EP antagonists? Well, EP antagonists, so we decided to test which were the receptors that were involved in this response. So we blocked the EP receptors, EP1 receptors. We performed a dose effect curve, as you can see here. And at this dose, the EP1 antagonist decreased the seizures, okay? Both the initial myoclonic jerks, so as the generalized seizures. The same for the EP3 antagonist. And importantly, this effect was prevented by PGE2. Therefore, not only the antagonist decreased seizures, but PGE2 prevented this protective effect of the antagonist. And at that time, we didn't have, at least for now, there is no EP2 antagonist. So, commercially available. There's only that one that was produced by Dr. Dingeldine's group. And we tested, therefore, the EP2 agonist. And we have found that EP2 agonist protected from the seizures, okay? So this is a picture of what we had. Celecoxib, by decreasing PGE2 production, decreased seizures. The anti-PGE2 decreased seizures too. The blockade of EP2 receptors, EP1 and EP4 also decreased seizures. All these effects were antagonized were prevented by PGE2, and butaprost by stimulating EP2 receptors also decreased seizures. That's okay. So, but I was very concerned about that. I don't know if you are used to that, but I'm used to teach pharmacology back home, And one thing that occurs, for example, if you have a given patient who is receiving propranolol, for instance, and you give him epinephrine, he has a huge increase in blood pressure. And this occurs because the beta receptors are blocked, and epinephrine therefore binds to the alpha-1 response, causing the increased blood pressure. So what we have wondered here is that PG2 might be reverting the effect, the anticonvulsant effect of the specific antagonist by activating the other receptors instead of blocking these receptors, instead of displacing the antagonist. So it was important to do that, and it was really important to have some specific agonists to test this. And that's what we have done. We had a contact from Ono, pharmaceuticals from Japan, and Christina has done these experiments, and importantly, these drugs were all given by IP route. And as you can see, the amount of drug is minimal. It's 10 micrograms per kilogram of mice. It's almost nothing. It's very interesting that the EP agonist facilitated seizures, decreased the latency for seizures, and the antagonist increased the latency for seizures. And, of course, it was really important for us, the antagonist prevented the effect of the agonist. So it was like this for the EP1, for the EP3, absolutely the same results. The antagonist increases the latency, and then the agonist prevents this effect. And at last, we tested also the effect of another EP2 agonist that we received from Ono, and we had absolutely the same effect. That is, it increased the latency to seizures. Okay. Well, so the picture evolved in such a way that we were very sure that EP3 receptors was involved in this effect because we had at least two different drugs, two different antagonists that cause this effect, and also for EP1 receptor. But we also tested the EP4 antagonist and EP4 agonist. But however, we did not replicate the same results that we had with the first antagonist. And we became really concerned with that. Well, this may have an explanation, and that's why it didn't work. It's now fairly known that the EP4 receptor has a non-canonical signaling, and it may, depending on the ligand, depending on the expression of adenylyl cyclase, a sensitive adenylyl cyclase, sensitive to GI alpha, it can cause different effects. So that's probably the reason why we didn't have consistent results, because of the diversity of the intracellular coupling of this receptor. Well, another thing that was very interesting for us is that we have found that the EP antagonists were really they had more efficacy than the COX-2 inhibitors. And this made us wonder that COX inhibition might cause a diversion in the pathway, in the arachidonic pathway, and maybe it was driving the synthesis of a proconvulsant metabolite. And we wondered, since I have asthma, so it's a good idea, and it's not good for me, but it was good for us as a group, because I can't use aspirin, because I have bronchoconstriction due to that. And it's known that it causes increased production of leukotriene, and these leukotrienes might be involved probably in these effects of COX-2 inhibition. And we have decided to test the effect of CysLT1 inverse agonist, montelukast, and we have found that montelukast has an anti-seizure effect. We also found that it has a very important synergistic effect with phenobarbital. So, as discussed by Dr. Alfonso, sometimes our animal models doesn't show interesting things, but here we have found a very important effect, synergistic effect between this anti-inflammatory drug, which is montelukast, which is currently used in the clinics, and phenobarbital. And after that, we have found that this sort of association was patented by Ono in 2007, so they knew it worked. So at last, this is a review of the picture, and we have proconvulsant receptors, EP1, CysLT1, and EP3 receptors. They are probably causing this by increasing calcium inside the cells, and an anticonvulsant action of EPT, EP2, and also DP1, which was the work of Kaushik that was mentioned yesterday, that these receptors are coupled to GS and to increase it cyclic AMP levels. Well, I would like to thank all the institutions that have participated in this work and all the supporters. And this work had the important collaboration of Dr. Garrido Sanabria from the University of Texas at Brownsville. And well, that is. Sorry, people.
Thank you. So we have time for a few questions.
Please, doctor.
So it's first question is how specific are these agonists and antagonists?
Oh, they're very specific. I have a table, and they are at least 100 times more specific than to any other receptor tested by Ono. At least 100 times.
Okay, yeah, because a lot of studies showing the EP2 kind of receptor is really kind of protective or detrimental.
Of course.
So your study is just the opposite. So when you activate EP2 receptor as anti-epileptic effect.
No, not really. These studies you were referring at the studies from Dingeldine, and he has published that, for instance, that stimulation of EP2 receptors decrease seizures. The fact that most of the people confound seizures with cell death. In fact, the stimulation of EP2 receptor causes cell death.
Right.
And causes cell death, but decreases seizures.
Oh, okay.
By no means I'm saying here that we should use EP2 agonists to decrease seizures, because we don't know the mechanism by which they decrease seizures. But it's absolutely clear that EP2 receptors cause cell death. And increase canic acid cell death.
Okay, sorry, I'll ask you another question. So, because all you showed is in the neurons, in the synapse. So, is there? How about in the glial cells and microglia cells?
Okay.
The other question is.
Yes, I have positioned here